Thank you. This is very exciting. All I can say is, wow, what a morning. I've learned so much. What I'm going to do, though, is I'm going to completely change the framework here from one of lymphedema, which I didn't know anything about, to one of wound healing. Because the way I got to know lymphedema was patients would have their cellulitis over and over again. Then they would have a wound. And they'd have a wound for sometimes several years, 5 years. And then they'd finally come into the wound center, and it was like, oh boy. Well, the first patient I had heard a lecture at one of the national meetings on lymphedema. And I said, I need a lymphedema therapist. I was at Hartford Hospital at the time, 800-bed, level 1 trauma. We have everything. We didn't have a lymphedema therapist. So I sent them over to St. Francis Hospital. They got lymph therapy, and that wound closed up just like that. So I said, aha, I get it. I understand what it takes to heal wounds in lymphedema patients. In fact, I like seeing lymphedema patients come in because I know I'm going to get the wound to heal, as opposed to some of the other awful wounds that we're asked to deal with. So no disclosures, conflicts of interest, none. I'm going to disclose I have 2 wound pictures, and if anybody, I've tried to remember to warn you if you don't want to look at them, but they're the most mild wounds I could pick to represent kind of what I'm trying to say. So really, I'm going to try to touch on these topics. But the biggest one that people want to know about is cellulitis. Well, I want to tell you how you get to cellulitis. And I think I'm going to tell you 2 really new, exciting ideas that kind of I've hatched along the way, just from talking with patients, watching patients, and then reading my science book to get kind of ideas on what's really happening. And again, it's from a wound perspective. And what I want to say is that this edema and all these other bad actors happen because of chronic inflammation. And that it's the chronic inflammation that's really the problem here. If edema just was benign, didn't cause inflammation, you could live with edema, it wouldn't cause trouble. But all the other things, the cellulitis, the fibrosis, the pain, all of that is from chronic inflammation. So we know what edema looks like, but what exactly is edema? What is edema fluid? We all heard an elegant talk about already the trains, the yellow trains, the blue trains. The heart pumps out 1,000 to 2,000 gallons of fluid a day. And what is important to know here is transfer of metabolic products. Glucose, oxygen go in, carbon dioxide, and waste products go out. You have to have a lot of fluid coursing through your system to keep the cells happy. And in my situation, we see the blue train gets plugged up. It gets backed up. And now everybody's jumping off the blue to get on the yellow line, and then the yellow line goes down. And then they get cellulitis, and then they get wounds. And then they come into us. So we've got both lines are down now, and a wound that's draining all the lymph fluids now draining and decompressing through the wound. Here's the number 1 new thing, which is the interstitium, the interstitial space. That's where edema hangs out, and that's where it does its evil work. And what this is this is skin, this is the muscle, and here's the fatty tissue, the subcutaneous fat, and there's different layers, and there's strands that hold everything together. And in between those strands are spaces, and that space is not normally full of fluid. It has a little bit of fluid, but when you become edematous, this space builds up. And here's the blue and the red in the blue, and there should be yellow in there in terms of the train analogy. And what happens is as the fluid builds up in here, you start to get inflammation, and then inflammation causes a whole cascade of bad effects. And so I'm a scuba diver, and I thought this was a good kind of analogy. This is really cool. One of the hurricanes in the Gulf uncovered a submerged forest. And what you're looking at is water around the trees. So the water is really the edema fluid. And in here would be the skin up here, up at the top. Uh-oh. And then your blood vessels are down in here somewhere. And that's the outline of the interstitial space in the fluid that will collect. New York Times had a wonderful article about new discovery of a new organ. And I'm like, what, a new organ? A year and a half ago. What's that? Well, it turns out they're talking about the interstitium, which scientists have known about forever. But like everything, it goes into popular press, and suddenly you realize, well, there is something to this. And what people are looking at now is, of course, cancer. And does cancer migrate through that interstitial space, just like you saw those fish wandering through? Well, I think cancer cells are probably going through there, so it's opened up an avenue of, hey, maybe we can stop them right in that interstitial space. I believe that infection, cellulitis, all the other bad things that are happening in lymphedema are doing the same thing. They're following that space. This is actually what it looks like. The histologists for years, maybe I gotta grab this one. Histologists for years have been looking at tissue preparation like this, very thin, and they dehydrate it with alcohol, so all the fluid is removed. If you don't dehydrate it, you get this, which looks like Swiss cheese, and all these holes are the interstitial space. So every tissue in the body has these holes and is full of interstitial fluid. So, wound healing. So before I talk about cellulitis, I want you to understand wound healing. The primary, everybody's cut their finger, and what happens? It gets red, it gets sore, it gets swollen. Those are the classic signs of the inflammatory response. And wound healing is fundamentally and initially an inflammatory response. It's acute inflammation, and it's good because it revs up all the white blood cells to fight infection. It can be bad, though, if it's left unchecked. And that's kind of what happens with chronic diseases. So this wound healing response, initially it's inflammation, and actually you heard the word hypertrophy today, the fat. That's because these edematous legs are really in both the first inflammatory but also second proliferative phase of wound healing, and all the tissues are trying to grow and repair a wound that the body thinks is inside the leg. And so you get this robust wound healing response, and you get what? A scar. That's the fibrosis. That's the normal outcome of healing of a dermal wound. It's an abnormal outcome in long-term protracted inflammation that's related to lymphedema. And so if we can decrease that inflammation, we can make all these other things go away. So why is there inflammation in that finger, that cut? Turns out nature, in its wisdom, has blood, and blood goes out into the cut finger, and it releases both red blood cells, but a lot of proteins. One of the proteins clots the blood vessels, but many other are pro-inflammatory. What they do, the whole purpose, is they call in the immune system to say, we got a breach in the system, all hands on deck, kill the bacteria that are going to invade. Okay, so now come the lymphedema situation. The blue the blue train is plugged, the yellow is plugged, things start leaking. The capillaries start to leak, and the capillaries start leaking out protein. The protein goes into that interstitial space, and it causes inflammation. The inflammation, in turn, makes this leaking worse. So you have a positive reinforcing cycle going on that will not ever stop until you can control the inflammation in that leg. So we all know most of the chronic diseases in this country, in developed countries, are due to inflammation, chronic inflammation. It links a lot of different diseases. I won't get into the details, but rheumatoid arthritis, inflammatory bowel disease, etc. I've already shown you that wound healing on the left here is a good thing. It's acute, it's short term, and it leads to scar. Chronic inflammation eventually erodes the surrounding tissues and leads to disease. And that's really the same thing that's happening in lymphodematous leg. And here's a nice picture. It's easy to say, well, how can I recognize inflammation? And so this is, anybody can recognize this, right? A mosquito bite in a young child. It's red, it's hot, it's might be a little bit tender, it becomes itchy. This nice cartoon lets me remember how to remember the signs of inflammation. And it's going to be hot, it's going to be red, it's going to swell, it's going to hurt, and guess what? It's actually dysfunctional. So if you have hot red swelling, you don't want to walk on your leg, you got to be worried. You have not cellulitis yet, or classic cellulitis. You have inflammation. That may be inflammation from the leaking proteins. It may be inflammation from the bacteria that have now entered into your system. So itis, cellulitis is just, itis means inflammation, arthritis, appendicitis, diverticulitis, dermatitis, and cellulitis. They're all just inflammatory states. And so here's two classic examples of what I call BLE. And this is cellulitis, but it's not infectious bacterial-driven cellulitis. It's protein inflammatory cellulitis, or what I call biochemical cellulitis. And it's BLE is the name I use because it's bilateral lower extremity erythema and edema. And this doesn't need antibiotics. This needs compression. And yet if you go into your emergency room with this condition, you will be in the hospital for a couple of days of antibiotics. Your legs will be up. Things will kind of get better, and everybody say, good, antibiotics worked. You go home with the pill, and then 4 days later, the pill's end, and 2 weeks later, your legs are swollen, and 2 months later, you're back with the same problem over and over again. And nobody stops and says, are you compressing these legs? And I think that's a problem in the medical profession that is totally under-recognized. And hopefully we can change that. If this goes on long enough, this is the advanced stage. What I like about this picture, this is papillomatosis, right? Dermatofibrosclerosis. It's a sclerotic, fibrotic leg. That's wound healing. And so when I see a patient with this thickened skin means you can heal the wound. There's not a defect in healing. So again, I just showed you this is the biochemical. You have bilateral inflammation, no antibiotics. Now here's the problem. This is a recent paper that was written reviewing cellulitis because there is an epidemic. It's a huge problem nationwide, worldwide. And what is interesting is 33% are misdiagnosed, and look at the cost of $515 million. And a lot of it is due to the fact that we are not differentiating inflammation that's caused by biochemical proteins leaking into the system versus bacteria invading the system. And we need to get better at that. And it's a whole avenue of potential research. So here's my picture again. So now the bacteria are the fish. The bacteria wander in, but also the lymphedema. I learned today lymphedema is right on the same path. And you heard about all of the debris, the cellular debris. Guess where it hangs out? It's going to clog this whole interstitial fluid space. And what it does is it calls in white blood cells to cause more inflammation. That makes the blood vessels become more leaky, and you'll never get out of that situation without managing the edema. So how do I know if it's inflammation from the proteins or inflammation from bacteria, right? Two major findings, and this is also my big take-home, okay? So, you know, the interstitium and now this. The two are that it's going to be in one leg and it's going to happen quickly. So patient goes to bed at night, wakes up the next morning, it's painful, it's red, it's swollen. That cellulitis, don't wait, go see your doctor. Don't delay. The sooner you get treatment, the faster it will resolve. And the problem with it is the edema or the cellulitis worsens the lymphatic function and makes you more prone to cellulitis later on. I just throw this up because and it's in your references, but it's some of the guidelines from the lymphedema societies. And there's always this question about massage and compression when someone has cellulitis. I can tell you the best way to treat the cellulitis, whether it's bacterial or infection, is to compress, to reduce the edema. It will improve drug delivery, it will improve oxygenation, it'll improve immune function in that leg. There's a debate about the massage, and I can understand why. If your interstitial space is full of debris, and that debris is mostly bacteria, I probably wouldn't want to massage that off into my bloodstream. I want to let things settle down a little. But I think using judicious compression to control the swelling during that time is really important. Okay, so edema is the biggest risk factor for cellulitis. And it's like the edema isn't bad, it's the inflammation that's bad. And that causes all these other changes in the immune system and in the function of the skin to allow the bacteria to then invade. And what you can see over and over again, it's a recurrent disease. And so what I say is acute cellulitis is a chronic disease. It's chronic mainly because of the way medicine manages it, is they manage it like it's an acute disease. It's not. It's a chronic disease. And you can see the other big risk factor here is the chronic edema. And again, when you get cellulitis, edema makes cellulitis, cellulitis makes edema. Another vicious cycle, another positive reinforcing cycle that you need to break. Another paper, again, whether it's primary cellulitis, recurrent, over and over again, you see edema is a major driver for risk factor for cellulitis. So can you make cellulitis go away, or can you prevent cellulitis is the million-dollar question. And I say yes, I'll show you some data on it. But so what do we do? We'll control edema. I would say that should be the first three things on the list. Avoid injury, obviously. Avoid cellulitis, well, control your weight, blood sugar, all these other things. Prophylactic antibiotics, we already heard a little bit about. I got the flasher going here. But here's the biggest point here, is with a community-based management system, you can reduce lymph volume, and that will drop the incidence of cellulitis from 41 down to 0 over a 6 to 12 week. So you can prevent cellulitis. It's not hopeless. The other thing we heard about was exercise. And it's not exercise like this high-intensity stuff that you see everyone trying to do. It's get out and walk. Hippocrates knew that. And here's why, because of the calf pump mechanism. And we know it increases venous blood return, but it also massages all of that interstitium. It gets the interstitial fluid moving, and that's what you want to do. So here's the BLE, bilateral lower extremity erythema and edema. Cellulitis makes leaky capillaries. Plasma goes into the interstitium and results in acute inflammation and scarring. That's my summary. I'm going to get out of here soon. For the therapists in the room, it's a lot more complicated than what I just said. And it's really exciting because we're learning a lot of the components. I just addressed 2 or 3 things on this diagram. So there's a lot to be done. Here's the interstitium again. There's all kinds of immune cells. We saw CD34 cells and NF-kappa beta and all this other interesting stuff that's going on. I think there's a big opportunity to study what's happening in the interstitium. Complications, I was going to do wounds, but I knew wounds aren't a big problem in these patients. Find a wound care center that can do moist wound care, but more importantly, find lymphedema therapists that can control your edema. And here's one of the wounds. Patient's been out for many months, changing the dressing 10 times a day. It's basically, I say they spring a leak. And that you can't heal that wound as long as all that lymph fluid is decompressing through that space. It's like trying to patch a dam while the water's running through the dam. You're not going to do it. Here's another one. This patient was over 2 years. By good compression lymphedema therapy, we closed this patient in 3 months. And he had no ability to close prior to that. So you must control the edema for the wound care. Moist wound care is critical. There's newer dressings that, again, you need to just be at a comprehensive wound care center. And then a little bit about the psychosocial issues. So, you know, it's really, I treat patients and I understand what it does to their lives. It's devastating. Well, the Greeks knew that, and they wrote a nice little story about it, which you may want to look up. But this was a big warrior who was on his way to Troy to fight a big battle, and a snake bit him in his ankle, and he developed a wound that wouldn't heal. And it was painful, he couldn't walk, and it really smelled bad. So guess what his comrades did? They left him on an island. They ostracized him onto an island. Unfortunately, as the story goes, they had to come back and get him because he had Heracles' bow, which never misses its target. And they weren't going to win the Troy War without that bow. So they had to come back and get him. But the point being that a little wound like this, right? A little wound took down a big guy like that. And that was known in the Greek times. And I still see this problem today. So I appreciate what you're all going through, and I'm here to help. So thank you for your attention. I guess we'll do questions.